who missed. We end up our this meeting with Professor Ehab Khairy. Dr. Ehab Taban is a very well-known figure, and he's an excellent speaker. وهو بعتبره ابني البكري في clinical nutrition. So let us welcome Dr. Ehab, and he will have a talk about probiotic in functional GIT disorder. تفضل Dr. Ehab. Thank you very much.
بسم الله الرحمن الرحيم. طبعا برحب بحضراتكم جميعا. First of all, thanks to Sandoz for supporting this meeting, which is done in collaboration with the Arab Society of Pediatric Clinical Nutrition, headed by Professor Dr. سناء. شرف لي الحقيقة إني أتكلم في وجود أستاذتي ومعلمتي الأستاذة الدكتورة سناء يوسف. أنا عارف إنكم تعبتوا مش كده؟ بس يعني أنا I'll try my talk to be a light talk. I'll talk about probiotics in functional gastrointestinal disorders. I'll cover what are the functional gastrointestinal disorders and what are the benefits of probiotics and its role in functional gastrointestinal disorder. First of all, we should know that 65% of gastrointestinal diseases in infants and children are due to functional disorders. Organic disorders constitute only 25% of all gastrointestinal diseases in infants and children. What is meant by functional gastrointestinal disorders? Functional gastrointestinal disorders are variable combinations of age-dependent, chronic or recurrent gastrointestinal symptoms. But there should be one important point. These symptoms could not be explained by biochemical or no associated biochemical or structural abnormalities. So if we have no biochemical or structural abnormality and we have a combination of recurrent or chronic gastrointestinal symptoms, this is called functional gastrointestinal disorders. Actually, the etiology of functional gastrointestinal disorders multifactorial. Multifactorial, but in the recent years, the importance of intestinal microbiota in the development of functional gastrointestinal disorders come to the focus. And so, a lot of studies nowadays are focused on the potential role of probiotics in prevention and the treatment of functional gastrointestinal disorders. This is the etiology, which is a complicated etiology of functional gastrointestinal disorders. It is multifactorial. We have early life genetic and environmental factors like problems in the early life, like exposure to trauma, infection, and sometimes the culture may affect, and some environmental factors like child abuse, like behavior of the parents, social learning, diet, and the use of antibiotics. All these points may affect the brain, either psychological effect over the brain, like inducing some cognitive affective processing disorders, and some health and anxiety and stomatization disorders, and some gastrointestinal specific anxiety. At the same time, it may lead to disorders in the functional network connectivity of the brain and may lead to visceral hypersensitivity and affection of the neurotransmitter. So these factors may affect the brain and at the same time may lead to physiologic effect on the gastrointestinal tract, affecting motility, sensitization, and secretions, immune cell function, and inflammatory cytokine. This problem in the physiology of the GIT and in the brain can lead to the functional gastrointestinal disorder with different symptoms, different severity. And unfortunately, this will affect the quality of life, daily function, and may lead to use of a lot of medications, which are unnecessary medication, and will abuse the hospital and general practitioner activities and leading to a lot of visits. This is in a simple way what will lead to the functional gastrointestinal disorder. Functional gastrointestinal disorders are classified according to Rome 4 criteria. Rome 4 classification, which is the most recent classification of functional gastrointestinal disorders, divided the functional gastrointestinal disorders according to the age. Either functional gastrointestinal disorders in neonates and toddlers or in children and adolescents. In neonates and toddlers, these are 7 categories: infant regurgitation, infant rumination syndrome, cyclic vomiting, infant colic, functional diarrhea, functional dyschezia, and functional constipation. As we can see here, 40% are of the functional gastrointestinal disorders in infants and neonates are infant regurgitation, 25% are infant colic, 15% are functional constipation. And actually, up to 50% of infants in the first year of life will present by one of the 3 conditions, either regurgitation or infant colic or functional constipation. Then, this is a very important point we should know. Functional gastrointestinal disorders in infants and neonates are never, or is never, a reason to stop breastfeeding, because a lot of healthcare professionals, practitioners are stopping breastfeeding in cases when the patient develop functional gastrointestinal disorder. It is not a reason to stop breastfeeding. In children and adolescents, we have 3 categories of functional gastrointestinal disorder. First category is functional nausea and vomiting disorder. This includes cyclic vomiting syndrome, functional nausea and functional vomiting, rumination syndrome, aerophagia. The second point is functional abdominal pain disorders, and this includes functional dyspepsia, irritable bowel syndrome, abdominal migraine, functional abdominal pain, not otherwise specified. Okay? The last is functional defecation disorder, whether functional constipation or non-retentive fecal incontinence. These are the Rome 4 criteria or classification of functional gastrointestinal disorders. This is according to the age. Infant regurgitation can occur in the first year of life. Infant colic usually in the first 5 months of life. Functional constipation can occur throughout neonate infancy and childhood and adolescence. Functional abdominal pain disorders usually develop between 8 and 18 years of age. I'll focus on the functional gastrointestinal disorders that can lead to pain. Actually, abdominal pain is a common symptom in children and adolescents. Usually, abdominal pain occurs in patients having gut barrier dysfunction, dysbiosis, mucosal inflammation, or dysmotility. And these are the most common painful functional gastrointestinal disorders in infants and children: infantile colic, functional dyspepsia, functional abdominal pain, and irritable bowel syndrome. Functional gastrointestinal disorders actually will lead to a lot of troubles and have a lot of impacts either on short term or in long term. The immediate impact of functional gastrointestinal disorders will be feeding problems and stress in the family and marital problems. And also it will lead to exhaustion of health economics. Actually, a lot of visits to doctors, to hospitals, are due to infantile colic, regurgitation, constipation, or abdominal pain. On the long term, they will affect the quality of life of the family because 28% of infants with infantile colic will develop functional gastrointestinal problems later on in life. So, presence of functional gastrointestinal disorders early in life will lead to problems later on in life. So actually, it's very important to prevent them early in life. Now I'll discuss with you some of the painful conditions. First of all is infantile colic. Infantile colic diagnosed according to Rome criteria as follows. Baby having crying or fuzziness or irritability lasting more than 3 hours per day without obvious cause. This should occur at least 3 days per week and continuing for more than 3 weeks. Okay? This should happen in infants less than 5 months of age, and there is no evidence of failure to thrive or any illness. This baby during the attack, usually he will be excessive crying, grimacing, redness, clenching of the hands, and flexing the lower limbs over the abdomen. And it's difficult to calm this baby. Change diaper, trying to calm him by all known methods will usually fail to calm him. Infant colic is very important. This research or these statistics, you know that we have moms group, we have social media. They found that most of questions over on the social media and on the moms group are for infant colic. About 43% of parents search on the internet for the information about baby colic or infant colic. Colic will affect the parents. It will lead to exhaustion of the family, psychological disturbance of the mother, which may lead to breast milk failure, will lead to marital stress, postpartum depression, and shaking baby syndrome. You know, shaking baby syndrome that may lead to intracranial hemorrhage or fractures in the baby. Infant colic is multifactorial. It may be due to trapped intestinal gas, due to reflux, due to milk protein allergy or any other food allergy, may be due to lactose intolerance, may be due to external stimuli and stressful external environment. But recently, bacterial imbalance seems to be associated with infant colic. And research has found that infant colic is associated with and preceded by altered gut microbiota, which is the dysbiosis, suggesting that this dysbiosis may be related to its development. The other painful gastrointestinal disorders are the functional abdominal pain disorders. Functional abdominal pain disorders is a multifactorial problem. It started usually early in life by painful somatic stimuli or even neonatal repeated gastric suction, sometimes genetic predisposition, and gastrointestinal infections, exposure to allergen with mast cell dysfunction and serotonin release. All these factors, besides some psychological factors, any psychological factor, abuse, separation from the parents, separation from best friend, hospitalization, any other psychological factor, also poor gastric emptying and abnormal gastric accommodation, dysbiosis and alteration of gut microbiota, abnormal rectal sensory threshold. All these factors will affect the visceral hypersensitivity and dysmotility, and this will lead to functional abdominal pain. This can occur with any person or any child or any adolescent. According to Rome 4 criteria, these are the criteria for diagnosis of functional abdominal pain disorder. I'll mention everyone. Irritable bowel syndrome, which is the commonest. To diagnose irritable bowel syndrome, and by بالمناسبة, irritable bowel syndrome is very common, but usually undiagnosed. But if you apply Rome criteria, you will diagnose a lot of cases of IBS or irritable bowel syndrome. The criteria should be present at least 2 months include all the following: abdominal pain at least 4 days per month, يعني 1 day per week at least, associated usually with defecation or change in the frequency of stool or a change in the appearance of the stool. When you have abdominal pain once per week associated with one of these, and does not resolve with the resolution of constipation. So if the patient have constipation and abdominal pain, and with resolution of constipation the pain resolved, it is not irritable bowel syndrome. And you should find that after appropriate evaluation, the symptoms cannot be explained by other medical conditions. If you revise all your patients coming by abdominal pain, you will find a lot of them fulfill the criteria of irritable bowel syndrome. Functional dyspepsia, another functional abdominal pain disorder. Also, the criteria should be present at least for 2 months before the diagnosis. One or more of the following: at least 4 days per month, which means at least 1 day per week. Postprandial fullness. بعد الأكل, you are feeling fullness. And rapid satiation. Early satiation means early stoppage of food due to sense of fullness. Epigastric pain or burning, not associated, burning sensation, not associated with defecation. And all these, after appropriate evaluation, cannot explained by any other factor. The third problem is functional abdominal pain, not otherwise specified. Also, the same should be present at least 2 months, 4 times per month. Episodic or continuous abdominal pain, not associated only with physiologic events, يعني not associated with menaces or eating, and cannot fulfill the criteria of functional dyspepsia or irritable bowel syndrome. These are the main functional abdominal pain disorders in childhood and adolescent. The most common one is irritable bowel syndrome. It is the most common functional disorder of the GIT. It causes a lot of symptoms: abdominal cramping, bloating, gas distension, and it may be associated with constipation or with diarrhea or with both, alternating. It is a chronic condition. Most of patients having mild to moderate symptoms. A small number of patients will have severe symptoms, and in mild to moderate cases, they are managed by modulating the diet, modulating lifestyle, avoiding stress, but severe cases may be treated by medication. Irritable bowel syndrome, recently in 2022, they mentioned that irritable bowel syndrome will occur due to abnormality in diet, excess diet fat or excess fermentable carbohydrate, and exposure to stress and psychiatric comorbidity. This will alter host immune function and alter intestinal physiology, and both of them will lead to dysbiosis, and this dysbiosis will lead to altering of microbial habitat in the gut, and this will lead to disturbed gut function, and we will enter a vicious circle. The disturbed gut functions will lead to disturbed intestinal microbiota, and intestinal microbiota will disturb gut function. So they start to mention that dysbiosis, one of the most important factors that can lead to irritable bowel syndrome. Now, what are the possible rules of probiotics in functional gastrointestinal disorders? We know that. أعتقد ياسمين covered that in 2000, American FDA declared that majority of probiotic organisms are safe, and the World Gastroenterology Organization published guidelines based on evidence that probiotics are effective in preventing colorectal cancer, preventing and treating gastroenteritis and antibiotic-associated diarrhea, eradication of H. pylori infection, preventing and treating hepatic encephalopathy, and improving immune response. In 2020, American Gastrointestinal Association published its updated guideline, and they mentioned or recommends the use of probiotic for preterm and low birth weight baby to prevent death from necrotizing enterocolitis, lessen the number of days required to reach full feeds, shorten the length in the hospital stay, and also can be used in prevention of Clostridium difficile and the management of pouchitis. And lastly, they recommend the use of probiotic in management of IBD and IBS, inflammatory bowel disease, and irritable bowel syndrome. Regarding probiotics in functional gastrointestinal disorders, this paper was published 2018. They mentioned that we have a lack of knowledge about the actual causes of functional gastrointestinal disorders. So they start to think about the role of probiotics, and not only in the treatment, but also for the prevention. But up to this time, there is no evidence for this, and they mentioned that although evidence for this must be regarded as still very limited, it should be kept in mind that recommendation should be only to strains proven to have efficacy. As mentioned by Yasmin, now probiotics are strain specific. Each strain is specific for certain disorder, and they mentioned that in 2018, they will not recommend any strain of probiotic except after finding its efficacy in this point. Then a narrative review mentions that many studies have reported reduction of abdominal pain in children with infant colic and IBS when specific strains of probiotics are administered. طيب معنى كده they give recommendation? Actually no, because the studies was heterogeneous studies and small sample size, and the strains used were different, and treatment options were different, and they recommend ان يبقى في بعد كده well organized, properly designed studies ب large number of people بstrains معينه عشان نقدر نقول الافكاسي بتاعتها. Flavia and her colleagues in 2019 mentioned that probiotics might represent novel kind of therapeutic approach in pediatric population against infant colic. Okay, and they mentioned that further studies are needed for each specific formulation, which means for each strain to know the pharmacodynamic, pharmacokinetic properties of each strain to evaluate their application as a positive preventive and treatment strategy in infant colic. We have some studies about Bifidobacterium animalis subspecies lactis BB12 in infant colic. This study was done 2020. They give patients or babies who have infant colic, they give them BB12 versus placebo. And they found that about 80% of patients receiving BB12 have at least 50% decrease in the duration of crying. And they have significant decrease in number of crying episodes. And they concluded that supplementation with BB12 is effective in managing infant colic. The effect could be derived from immune and non-immune mechanisms associated with modulation of gut microbiota. Another two studies about BB12, one was done in Italy, 2020, on 80 breastfed infants with excessive crying. They were given 10 to the power of 9 colony forming unit per day for 28 days. Actually, this increased the treatment success in the form of reduction of duration of crying more than 50%. Another randomized control trial was done in China on 192 full-term infants, less than 7 weeks, breastfed with colic, and also given 10 to the power of 9 colony-forming unit BB12, and this improved the colic. This is the most recent recommendation by Espagan, and this recommendation was on February 2023, just 4 months ago, about the probiotics in infant colic. This is the recommendation. They mention that healthcare professionals may recommend Lactobacillus reuteri for 10 to the power of 8 colony forming unit per day for at least 21 days for the management of infantile colic in breastfed infants. No recommendation can be made for the same strain for or against the use of reuteri in infants formula fed with colic. They may recommend bifidobacterial lactis BB12, 10 to the power of 8 colony forming unit per day for 21 to 28 days for the management of infant colic in breastfed infants. Okay? And no recommendation can be made against or with the use of any of probiotics studies in preventing infantile colic due to insufficient evidence. So they recommend reuteri and bifidobacterium lactis BB12 in the management of infantile colic. Regarding the functional abdominal pain disorders, this paper was published 2022 about the use of probiotics and some phytochemicals in management of functional abdominal pain disorders. They recommend the use of probiotics, whether Lactobacillus species, bifidobacterial species, or E. coli species, and phytochemicals like flavonoids, phenolics, and curcumin. This will lead to gut microbiome modulation and balanced firmicutes bacteroid ratio, and this will lead to limitation of symptoms in painful functional gastrointestinal disorders like IBS and functional dyspepsia, and this improved the quality of life. They also mentioned that in patients having IBS, irritable bowel syndrome, we have a lot of options for the treatment. I focus on what is important for gut microbiota. They mentioned that fecal microbiota transplant by bifidobacterium rich donor feces can be used. Probiotic bifidobacterium species, bifidobacterium lactis and infants, lactobacillus, streptococcus, saccharomyces, and lactobacillus rhamnosus. They recommend also the use of symbiotics, yogurt containing fibers and bifidobacterium lactis, inulin and bifidobacterium lactis. They also recommend the use of prebiotics like lactose, phos, gos, and others. And they recommend dietary intervention by diet low in fermentable oligosaccharide, disaccharide, monosaccharide, and gluten-free diet. ده غير التريتمنت اللي ممكن باي drugs. بس actually we try to manage these conditions without the use of drugs. What is the role of probiotics in IBS? Probiotics will restore gastrointestinal health, will restore colon microbiota, will help to ease some of symptoms of IBS like bloating, gases, abdominal pain, and irregular bowel movements. My take-home message: healthy gut microbiota is a major pillar of health. Different factors, including genes, stress, diet, antibiotic therapy, infection, early life events, and lifestyle may alter the composition of microbiota. Their disturbance is called dysbiosis, may cause a lot of diseases. We can restore their balance by the probiotic use. Painful functional gastrointestinal disorders are strongly disabling at all ages and are often difficult to treat. They are common in patients having gut barrier dysfunction, dysbiosis, mucosal inflammation, and dysmotility. Many studies have reported reduction of abdominal pain in children with infantile colic and IBS when specific strains of probiotics are administered. But still, the heterogeneity of the studies, small sample size, different strains, different treatment options impair the assessment. Finally, we are in need for further studies for each specific formulation in order to characterize the pharmacodynamic and pharmacokinetic properties of each strain to evaluate their application as a possible preventive strategy if administered early in life, and this will be a great success of probiotics, and thank you.
Thank you very much, Dr. Ehab. طبعا, as usual, a very comprehensive and inclusive talk. And now we come to the end of our meeting. Would like to thank all the speakers, the attendees, physical and online. And we thank also our guest speaker from the Emirates and all people, attendees from anywhere. And we'd like to thank Sandoz for supporting this event. And the floor is open for discussion. If there are any questions, please do. هل حد له أسئلة؟ تفضل.
يعني متشكر لحضراتكم جدا على الميتنج الرائع ده. وبس انا عايز اضيف اضافه دينيه بس صغيره كده، ان ربنا عز وجل نبهنا عن الميكروبيوم في القران الكريم، والرسول عليه الصلاه والسلام برضه نفس الكلام. يعني في القران ربنا بيقول ان اني خالق بشرا من صلصال من حمإ مسنون. حمأ مسنون اللي هو الطين النتن او الطين المعفن. فطبعا كان تفسير الايه دي ان ربنا عز وجل خلى الطينه نفسها فضلت لحد ما اتملت بكتيريا وميكروبيوم، فاصبح الميكروبيوم موجود في كل جزء من جسم الانسان، خاصه في الجي تي بالذات. يعني كمان برضو استشفيت برضو من الرسول عليه السلام انه بعد الاكل كان دايما بيلعق اصابعه، فلعق الاصابع ده هو برضو اخذ للميكروبيوم الموجوده في الاصابع. ده المفروض ان احنا نشتغل عليه الحته دي، يعني ان برضو بناخد ميكروبيوم من الاصابع اللي هي موجوده من البكتيريا الفلورا اللي هي موجوده على الاصابع. طبعا احنا ما نعرفش الستاف ابيدرمايدس، لكن هي دي نوع من الميكروبيوم اللي هي اصلا بتغذينا يوميا. المفروض ان احنا حتى كمان انا لاحظتها على نفسي لما ان انا يعني بلعق اصابع فعلا بعد الاكل فعلا ما يبقاش في حموضه، ما فيش ديسبيبسيا، بيساعد جدا جدا في الريليف بتاع الديسبيبسيا. يعني كمان انا لاحظت كمان بالنسبه للطفل اللي بيلعق صبع ابوه او بيعض الكبير، يعني لو مثلا قرب منه كده مسك صبع الكبير بيعضه، يعني بيعض الطفل الصغير ده لما بيعض الكبير ده بياخد برضه ميكروبيوم من جلد الاب او صابع الام لما بيعضها كده يعني. وشكرا جزيلا.
ده كومنت مش سؤال.
نعم،
ده
دي اضافه بس.
طب في سؤال يا دكتور اونلاين.
لو في اسئله جايه من بره.
Question online says, what's the recommendation for the probiotic use in pregnancy?
Yes, there are. This needs another lecture sponsored by Sandoz. Well, now many research and many papers and many data on the use of probiotics during pregnancy and to support the GIT function, as well as to balance the good microbiota in a trial to change the dysbiosis if it is there, to improve it. It will never change it 100% unless you really change the type of diet. This is the key for it. And it is supportive, and you can start it, but there are certain species specific to this, and there are the duration when you start and when you stop. These are certain recommendations, and the International Scientific Association of Prebiotic and Probiotic has now a new position paper which we have to to go through it to tell you what is the latest update. But it is used definitely during pregnancy.
If I can comment question, regarding the use of probiotics in pregnancy, especially in the first trimester, relieving the constipation and the GI disturbance. There are also research on the use of probiotics in preventing preterm birth, and another recent paper about the use of probiotics in prevention of allergy in the offspring. So there's a lot of evidence there if Dr. Christos would like to add on this subject.
Thank you for your question. Can you hear me?
Yes, we can hear you.
Yes. I mean, my talk was not particularly for pregnancy and fetal life. And this is a potential benefit there because the sterile, uterus dogma, as Dr. Sana said, has been disputed now. But to be honest, I don't have the answer on this particular one on studies because I focus on the infant nutrition and the first 1,000 days. But possibly there is something there.
Yes. Yes, Professor Christos. It is within the first 1,000 days. The pregnancy period is within the first 1,000 days. So I believe there could be use of probiotics in pregnancy.
Whatever is beneficial for the eubiosis, it definitely helps. So far, we don't see a harmful effect of probiotics. They may not have some utility in certain diseases. However, we don't see a harm unless you have a central line, something we see in kids with in the hospital. Some of them are associated with fungal infections, but overall, the supplementation, the use in the formulas and or the commercial preparations, we don't see a harm at the moment.
Thank you. Thank you.
Thank you.
If I may comment, eventually, yes, I have went through the probiotics and the allergy. It is very related to the there are many studies now to comment on the diet of the mother. Could it prevent allergy in these young infants later on with the use of probiotics? Is it, with the modulation of the immunity and with the use of probiotics and the good diet of the mother, it can have later on an effect in preventing allergy and allergic disease in their offsprings and later on infants. Okay, any other question? Okay, I think you are. Yes. Huh?
Thank you, my professors. I have a question. How long duration can we use prebiotics in irritable bowel syndrome? Duration of using probiotics in irritable bowel syndrome.
بص هو in cases of infant colic 28 days, but in irritable bowel syndrome still they cannot judge what is the duration because it is a very long يعني البيريود بتاعتها more length عن infantile colic. So as long as you have the problem you will use the probiotic.
استاذن حضرتك بس هو بالنسبه للبريتيرم هو
بس كنت واثق
when to start preterm for preterm can be used routinely اللي هي البروبايوتكس يعني الامبولات مثلا انا عندي كذا حاجه مش عايز اقول اسمها تجاريه بريتيرم.
ياسمين mentioned the position paper of Espagan اللي هي 2023. They mentioned that in preterm baby we can use either rotary or BB12 to prevent necrotizing enterocolitis in the preterm baby.
انا بستعملها من زمان. اكتب من كده يعني.
What?
انا بستعملها من زمان يعني.
اوكي. هو in 2020 already World American Gastroenterology Society mentioned that it should be used in preterm baby. Okay, but they not specified. They mentioned probiotic. But in 2023, Yasmin, one of the slides you mentioned. Yes.
One question for you, Professor Christos.
Yes.
Can probiotics be included in IBD protocol treatments?
For inflammatory bowel disease?
Yes.
Yeah, I mean, from the recent ESPGHAN guidelines for ulcerative colitis, the E. coli Nisle 1917 can be used in mild to moderate ulcerative colitis, and the VSL3 for recurrent pouchitis. Apart from that, there's no other evidence in inflammatory bowel disease. The ulcerative colitis is called Mutaflor. It's from Germany. It's difficult to source. However, still, I have several patients. They have some relatives there, and they managed to get it. It's not available in UAE. I don't know if it's available in the rest of the Middle East, but this is the only one mentioned in the guidance for mild to moderate ulcerative colitis, and the VSL3 for recurrent pouchitis. For the ESPGHAN paper, Dr. Ehab mentioned, I put the link on the chat. Everybody can see it. It's freely available. All the ESPGHAN guidelines and position papers, they are available on the website. Everybody can access it for free.
Thank you so much, Professor.
Thank you.
Dr. Krister, you mentioned we can use it in mild to moderate severe. You said we
ممكن
can
بس
use it.
حضرتك تعلي صوتك شويه لان احنا مش سامعين.
Dr. Krister, you mentioned that we can use prebiotics in case of mild to moderate ulcerative colitis. So for how long we can use it?
I use it long time.
For how
And
long?
I have two
years?
Yes, there's no harmful effect. For the recurrent pouchitis VSL3, you try for 2 months. If there's no response, you have to use other measurements, antibiotics, sometimes even other medicines. But for ulcerative colitis, I use it as an adjunctive treatment if available to all my ulcerative colitis patients. I have 2 patients who are only on this E. coli Nisle 197, but they are very mild cases, very mild cases. They have even managed to stop the 5-SA agents, Pendasa or Azacol. But these are exceptions in the rule, I have to say. I use it mostly as an adjunctive treatment. But the randomized control trials quoted there on the ESPGHAN ECHO guideline, actually, they have managed to have a remission of disease only on this E. coli Nisle 1917. I mean, there's no harm from these studies.
Thank you.
Thank you.
Any more questions? Thank you so much, Dr. Sana.
Well, thank you very much for you all. Now we come to the end of our meeting. Thank you for our honorable guests. I wished you enjoyed the dinner with us here. And we hope we can meet again, all of us soon. Thank you very much. Okay.
Thank you.